Hi there, and welcome to episode 5, where, because of some recent cases, which are quite interesting, we're going to be talking about pericardial effusions. So this is going to be kind of a two-parter on pericardial effusions. Today we're going to be talking about the basics. So pericardial effusions and tamponade physiology, what we're looking at with reporting, and how to communicate with other people about this. And then next time we're going to talk about tamponade drainage, some complications. So clearly this is an important topic, one that is one of probably the major wins for point-of-care ultrasound, point-of-care echo, excluding a big pericardial effusion in someone who's peri-arrest or in the middle of an arrest. So it's important. It's generally quite easy to do in most circumstances. And just some nuances about some of the tamponade features are quite useful to talk about.
Yeah, Chris, I think it is a really important topic. It's also quite a fun topic as well. So we can, before we move on to RV assessment, I think it's good to interject with a few fun cases to sort of talk through. So I guess, the pericardium in health, there is obviously that lubricating layer between the visceral and parietal pleura. Physiologically, we have about 50 mils in there.
Yep.
And I think it's important before you get on to recognising the abnormal to recognise the normal. So
Yep.
we often, when we're reporting, we see what we call trivial or physiological pericardial effusions a lot. So we might just show that, if that's all right, Mark. So we've got that here, so parasternal long axis view, and what we can see there just next to the infralateral wall here, might just point that out, is we can see this slither of echo-free space, which is there in systole, but it disappears in end diastole, and that's the definition of a trivial or physiological pericardial effusion.
I guess it's important to say that there are lots of different causes for a pericardial effusion, or for this physiological amount of fluid to accumulate and to increase in size. Things like infection, so pericarditis, inflammation, rheumatological conditions, malignancy, uremia, trauma, cardiac, vascular problems, and, of course, as always, idiopathic causes. So the presence of a pericardial effusion is not necessarily indicative of what the underlying pathology is, but really what we're worried about is the physiological consequences of that.
Yeah, I guess from a critical care perspective, we tend to see these when the patient's had that tipping point where they've tipped into tamponade physiology, or even, as you mentioned about the iatrogenic sort of pericardial effusions where patients have been to cath lab and they come back and things like that. So we tend to see the severe end of the spectrum. A lot of pericardial effusions, obviously, we don't get involved with.
Yeah.
But that's why it's really important to recognise those features on echo. But I think we really must emphasise that the key is it is a clinical diagnosis. But the features of shock, that obstructive shock picture that obviously you have with tamponade, they're very late features, and so we need to be able to be confident in recognizing early features of tamponade, and I think that's where critical care echocardiography really comes into play, is trying to pick that patient early that might deteriorate if that left without a drain.
Particularly as some of the early features are things that are very non-specific, things like shortness of breath, things like tachycardia. They're all could be indicative of lots of different pathology that's going on, or various contributory pathologies that are coexisting as well. We see pericardial effusions, people have got an infection and they've got a chronic pericardial effusion, and then they decompensate because they've got less physiological ability to compensate for that.
Yeah, absolutely. I must say that, Chris, I'm very impressed that you're wide awake after your incredible night shift of 13 admissions. I think that's an European record breaker.
No pericardial effusions though.
Oh, yeah, disappointing.
Not that I saw.
But plenty of other echo things to keep you entertained.
Absolutely. So I guess, a quick discussion about what the features of a pericardial effusion are on echo. So this is a parasternal long axis view where you can see that compared to the image that we showed before, there's a greater echo-free space, both behind the heart and above the heart in the near field. And whereas in the previous image, in end diastole there was no fluid there at all, you can see that this still has some residual fluid there. What some of the key features? It's a hypoechoic region. it splits the left atrium from the descending aorta, and also you can see it above the right ventricular free wall as well over the RVOT. So this is definitely what you'd see if you had a pericardial effusion. And how would you be reporting this?
As I was going to say, there are a few key things when you're reporting, and I think sticking to the same structure every time, you know, you're not going to miss anything, and also it allows you to speak the same language. So size is important, in that we measure that. Obviously, we would stop this. I might just show that, and we would scroll to end diastole, which is actually what we're in now. And you want to measure end diastole, okay? So, and you're going to do it along a sort of perpendicular plane between structures, so here to here.
And there's not a key place that you would measure it. It's just where you'd measure it at multiple points and wherever it looks biggest, really.
Yeah, I would measure it in multiple points and then report, you know, places where it looks the largest. So the size is important. So if we think about that, so, you know, if it disappears in systole, then in diastole, then it's physiological. If it's less than a centimetre, it's a mild pericardial effusion. If it's between 1 and 2, it's moderate. If it's over 2, then a severe or a large sort of pericardial effusion. But I think it's really key to obviously emphasise, we'll get into this when we talk about the physiology, is it's not the size of the effusion that matters. It's all about that change in pressure for a change in volume, or the elastance of your pericardium. Exactly. That's important. So the rapidity of the accumulation is what causes the trouble, because the chamber hasn't had chance to expand. You get an increase in the pericardial pressures above chamber pressures, and that's when you start to get chamber collapse and obstructive shock. So it's the rapidity of accumulation. And I guess that's what's key for us in the critical care environment is, we often don't see the chronic renal patients that have got these chronic sort of pericardial effusions. We see them when either something's tipped them over or they've had some sort of disease process that's caused an acute or rapid accumulation of fluid within the pericardium.
Yeah, and for the... we're clearly going to go on to talk about some of the tamponade features, but for some of the basic sonographers or people who have done some basic accreditation, they're comfortable with finding pericardial effusions. Often it doesn't really matter what the size of the pericardial effusion is, or it doesn't matter all these other features, MV, inflow variability, and all this kind of stuff. It's not really relevant, because echo gets you one step further in the journey, and it allows you to refer early and to be able to say, look, we've got a patient who's shocked, they've got cardiomegaly, globular heart, they're tachypneic, and on echo they've got a pericardial effusion. Do you mind coming and helping us manage this patient? And it's really difficult for anyone to say no to something like that. It gets you one step further in managing them. Yeah,
absolutely. And you'll often, I think just recognise, so if you've got any undifferentiated shock patient and they've got a pericardial effusion, and perhaps you haven't got the skill set to look for all of these other features, which we'll talk through, then just saying, I've got a patient that looks like they've got obstructive shock, there's a big collection around the heart, can you come and help me?
Yeah.
I think that's really important. I would report, as I said, the size, and then the appearance of the effusion as well. So whether it is echo free, so you've got this big dark echo free fluid around the heart, which is probably the most common sort of form of effusion that we see. But of course you can have echogenic pericardial collections, and in that case you'd be thinking about blood. Often blood looks similar to the speckling of the myocardium, and can be really easy to mix those two up. And then things like infection, it could be pus in there, or exudative type of collections. And sometimes you can see sort of fibrin strands, and it can look all quite nasty if you've got someone with a purulent pericardial collection as well, which we've had recently, haven't we? So that's important. So the size, the appearance, and the location. So where are you seeing that collection? In this one that we're showing here, it's circumferential. You can see it in the posterior and anterior parts of the heart. But sometimes you might not see it anterior to the RV, and you can just see it in the posterior sort of dependent regions as well. So reporting where it is also important. And of course, there are limitations to TTE in certain patient groups. So, often in our group, it's actually hard to get parasternal long axis, as we've talked about, but particularly after things like cardiac surgery, where the collections can hide, and
very posterior collections,
very posterior, just behind the LA,
stenotomy with some air in the mediastinum, you just can't get good pictures.
And in that case, low threshold to proceed to transesophageal echo and things. So those are the things. And then obviously once you've described it, then you need to comment on specific features of tamponade, which we'll come to in a second. You were going to talk about differentiating pleural from from pericardial?
Yeah, I think this is really important because often you can get hypoechoic collections in regions of the heart. And we talked, looking at that image, we described the fact that pericardial effusions tend to split the left atrium from the descending aorta. And that's one of the really nice things. You can see that disconnect between the two that are normally adjacent to one another. And that's one of the telltale features of...
I think it's the most helpful.
It is.
It really is.
Yeah.
Because sometimes it can be tricky.
Yeah.
You think, especially if you haven't got lung ultrasound alongside your echo as well.
It can be really tricky,
Yeah.
really, really tricky.
Yeah.
And it is common that people make that mistake. So these are two
definitely.
examples where there's a pericardial effusion and a pleural effusion. Now, this one on the left is a pericardial effusion, and it is relatively obvious. You can see it all the way around, but this is just to highlight that splitting of the left atrium from the descending aorta.
Really important.
Yeah.
Because people get this confused actually more than you would think.
And then we're comparing this to a pleural effusion here, where you can see that the left atrium and the descending aorta remain glued together. And if this was all pericardial fluid, this would have split this because it's big, and you would probably see some fluid anterior to the right ventricle as well. So that's one of the key things in differentiating pleural from pericardial. I find that doing some lung bases as well can help too. Definitely. To make sure that you're, if you think this is pleural, they're definitely going to have a big pleural effusion at the base of the lungs as well.
Yeah, we'll definitely recommend doing heart and lung together, just using your same phased array probe and doing quick lung ultrasound.
Definitely. And then the other one to differentiate is pericardial effusions from ascites. And this is commonly from a subcostal window that you can see the two of them. Yeah. And this is an example that we've shamelessly stolen from the internet.
It's sad because we have got a lot of these, but we just haven't had a chance to save them. But you see this a lot. Yeah. And it's really important to recognise, because you don't want to be over-calling pericardial effusions when the patient's just got, not just got ascites, but got ascites. And as I think you were going to say there, Chris, so really the thing to notice is that falciform ligament, which you see a lot, and then that helps you a lot. And you can obviously see the parietal pericardium there as well, the big bright structure. Yeah, and clearly there's a pericardial effusion here as well. Which makes it easy. But it's important just to think, is this definitely pericardial if you see something in the subcostal window? Definitely. Because I've seen cases where you don't have that pericardial effusion and people have reported that ascitic fluid as pericardial fluid. For sure. All right, so we should probably move on to tamponade physiology, because this is really what... It's what we were meant to talk about. This was what we were meant to talk about, but as ever, we got distracted. But you're sleep deprived. I have no excuse for my waffle. We always waffle. Okay, so tamponade physiology. So this is really what we're worried about. People walk around with pericardial effusions all the time. You see them in outpatients all the time with big pericardial effusions that they're not compromised by. Yeah. So as fluid accumulates in the pericardial space, the main issue is when that intrapericardial pressure increases. And when it increases to a point where it exceeds the pressure of the chamber that it's adjacent to, then it can start to cause impaired filling and chamber collapse. So fundamentally, it impairs diastolic compliance, and it can lead to equalization of the mean diastolic pericardial and chamber pressure. So you get stasis of blood flow. So this is really what happens with accumulation. You get severe diastolic compliance issue and ultimately obstructive shock. Yeah. And death. Hopefully not. But as you've already said, so the rate of accumulation is the most important part. And people who accumulate fluid, very rapidly, even 1 to 200 mils, can tamponade. Whereas you can have people with several litres in their pericardium, but the pericardium has had time to expand, and therefore it can compensate for that. Yeah, absolutely. I think the nice thing to think, in terms of tamponade physiology, it's about that dissociation between your intracardiac and sort of intrathoracic pressures, isn't it? And also that respiraphasic variation and that ventricular interdependence. Yeah. Those are sort of the hallmarks of the physiology. Yeah. And obviously there's a bit of overlap, when we're going to move on to talk about constrictive pericarditis and things like that. There's overlap there, but it's really beautiful physiology, I think. And it really demonstrates the crux of what I think ICU sort of physiology is all about. It's about that heart-lung interaction. Yep. And we can detect that with echo, I think with more precision, and we can trend it, with echo more so than we can obviously without clinical assessment.
Yeah,
and that's why.
And so
important.
so some of the key features that we're going to talk about really demonstrate this physiology nicely. So we've already mentioned chamber collapse. So this is probably one of the most important things that we need to be looking for. It just relies on 2D imaging, so people who aren't familiar with using basic techniques can still use their standard imaging that they would do to identify this. And as we've mentioned, as the pericardial pressure exceeds that of the adjacent chamber pressure, then it can cause chamber collapse. So inevitably, this is going to happen first in the chambers that have the lowest pressure. Yeah. So classically, this will affect the right atrium first, followed by the right ventricle, and then it may lead to causing left atrial and ultimately left ventricular collapse, although you'd expect significant hemodynamic compromise before that.
Yeah.
And the timing of the collapse is really important, isn't it?
Yeah.
So if we start with the right atrial collapse that we can see here, so what kind of time of the cycle are we looking at that?
So the pressures in the atrium are lowest at end systole.
Yeah.
So you generally would see chamber collapse in that period, but I think more sensitive is how long in the duration that it's collapsed for. So we talk about more than a third of the cycle. If your right atrium be collapsed, increases the sensitivity for tamponade. But none of these markers, as we said, are 100% sensitive or specific. But yes, you'd be looking at end systole more than a third of the cycle. So you'd obviously need to pause and just scroll back and slow that down and check how long it's collapsed down for. That's often what I do.
Yeah.
And then obviously your right ventricular collapses in diastole. Now, a nice thing with that one, Chris, the one that we were just on there, is that we've got biatrial collapse, but we don't have any RV collapse.
Yeah,
and the
which
RV,
is quite unusual, really.
It is, but not. I don't think so unusual in our patient group, I must say, because we often have, patients with chronic pulmonary hypertension, with chronic RV sort of dysfunction. They've got that
on a ventilator as well.
On a vent, exactly. They're vented. You're putting up their pressures, an RV afterload from that, and you've got big RV systolic pressures, big beefy right ventricles. That often, the pressure inside is able to withstand what's happening outside. So we often don't see that RV chamber collapse, and which is why it's really important to integrate all of these things into what you're seeing clinically alongside other echo features as well.
Yeah.
If you see it, it's easy, obviously, which we can see nicely in this next one in the parasternal long axis view.
Yeah, so this is showing collapse of the RV outflow tract. So when it comes to right ventricular collapse, then the pressure is lowest in diastole. So classically, you can see this in the RVOT first, rather than the RV free wall, for example.
Yeah.
And the parasternal long axis view, which is often where we start our imaging anyway, is often one of the best places to see that. And just pointing out where this is, this collapse here is happening during diastole. And this is pretty obvious. There's a big circumferential pericardial effusion, and it looks like someone's jumping on a trampoline, pushing that right ventricle down.
Yeah.
But what you can do is place the M mode cursor through there, and although I've been slightly naughty here and I haven't put
very naughty there.
Put on the ECG tracing,
sonographers would snap out.
They would. So this is an example of another one where you've got side by side imaging of M modes, and you can see that during diastole you've got collapse of that right ventricular wall. And so this is quite a nice way of demonstrating that clearly. If you don't have the ECG on because you've been badly behaved like me, then you can also use the mitral valve excursion to identify where diastole is, which is it's a bit of a cheat, but something that's
but it's nice.
And this is that same case. So whilst there's no ECG, you can see that there's some diastolic collapse there. And this patient was tamponading, quite clearly tamponading, but it is quite nice to show this M mode trace as well.
Yeah. And also, so you can, the first thing that obviously that sometimes cardiologists and teams are going to ask you is, have you got RV diastolic collapse, and just to be able to send them, images like that or whatever, if you're is often helpful as well.
Yeah, definitely. So the next thing to talk about is variability in ventricular filling. So this is the echo feature of the kind of exaggerated ventricular interdependence that you were talking about. So just to remind everyone, so during inspiration, you reduce your intrathoracic pressure and you draw blood from your IVC into your right ventricle. And normally that will expand, but when you've got high pericardial pressure, the RV free wall can't expand. And so it ends up with the interventricular septum being pushed into the left ventricle. And so you get an increase in your right ventricular stroke volume or an RV filling during inspiration, but because of that compression, you end up reducing your left ventricular filling. So this is what the exaggerated ventricular interdependence is, and then the opposite happens during expiration. Yeah. And there are ways on echo that we can demonstrate this. And normally this will be relying on putting the pulse wave Doppler trace at the level of the mitral valve or tricuspid valve and showing a variability in the inflow. I think we've got an image here of the inflow of at the mitral valve level. So this is the LV inflow variability. And you can see just from a technical perspective that we have reduced the sweep speed of this spectral Doppler trace, so we can get multiple, quite a few cardiac cycles in there. And then you can measure the peak and the trough.
Of the E velocity.
Of the E velocity,
yeah.
And the what's a quoted number is over 25% variability is deemed to be slightly abnormal, and so this would increase the likelihood that there's this exaggerated ventricular interdependence going on. Yeah. And then if you're looking at the tricuspid, you normally get slightly more variability in this, and on this view you can see that there's a really marked variability, and the quoted value is over 40% for being abnormal for the tricuspid valve. But there definitely are some caveats to this measurement, aren't there?
Yeah, for sure. I think there's a lot of things you mentioned. Patients being ventilated is probably one of the most relevant for us.
Yeah, and in that, although you'd potentially expect a reverse relationship between when you get the peaks and the troughs, it's just not consistently. It doesn't consistently demonstrate that, and it's not validated to be used for diagnosing tamponade.
Yeah, it's not, and it's not quite as simple as like the reversus pulsus paradoxus that we talk about. And Andrew Hilton writes about this beautifully in the Critical Care Echo book. He was a real sort of aficionado talking about this heart-lung interaction and how all that changes. So it can be complicated, and it's why I don't necessarily just obviously we can't just rely on one of these things. It's putting everything together as we always say.
And because you're using pulse wave Doppler, it's just measuring at that one point. And with big effusions, your heart can swing and you can get variability in where you're getting this sample volume from. So you have to be very careful. And AF and tachycardia in itself makes it challenging. So this is something that I must be honest, I don't use very often in our population because there are too many situations where it's probably not valid.
Yeah, I mean, patients with raised left atrial pressure for whatever cause, diastolic dysfunction, mitral valve disease, all of that, they might not necessarily have that variation because they've got raised left atrial pressures as well. Yeah,
and the same thing you can see for for stroke volume variation. So for the same reason, you end up getting exaggerated stroke volume variation, and again, the same caveats. It's difficult to interpret with a ventilated patient. And again, with that swinging heart, you can get marked variation in your LV outflow tract or RV outflow tract trace.
But I mean, overall, I think we should still, if we've got someone with a pericardial effusion,
we still should do it.
This still should be within our...
particularly in an outpatient population. If we're scanning people who aren't acutely unwell, then definitely we need to be doing this because it's used to communicate between specialties and to...
Yeah, definitely do it, record it, state what it is. It's good for trending as well, but also just take it with a little bit of a pinch of salt, with the caveats we mentioned.
And here we've got an example of what it might look like on our arterial line trace. So all of these features, so the variability in ventricular filling or stroke volume variation, these are all the echo features equivalent to pulsus paradoxus.
Yeah.
And if we've got an arterial line in, then you can really easily see that, particularly with the respiratory phasity being shown on the screen as well.
Yeah, so that exaggerated drop in your systolic blood pressure during inspiration. Yeah, and as you say, it's just showing the same thing as what we detect on echo, really.
Yeah. Okay, so any other features that we need to be aware of?
I think one key thing is to look at the IVC.
Yes.
Obviously.
Yeah.
Classically, we would see a plethoric, so a big fixed IVC, signifying that you've got elevated filling pressures, elevated right atrial pressures. So that's really important to look at. And again, it just increases your confidence that you're dealing, with tamponade physiology. So crucial to look for that, I guess, and all of these things have got caveats, and so has the IVC.
Yep.
And we know that, patients can have low pressure tamponade and have a collapsing IVC, and often, giving these patients a little bit of fluid just to temper. It's often a temporizing measure, though, that that fluid. So it's important to obviously trend that patient, watch them very carefully.
Yeah, it buys you can buy you a bit of time while you're aligning everything, ready to fix the problem.
Exactly.
Yeah.
Yeah.
The other thing, just to mention, a lot of people talk about when that heart's swinging in the pericardial space. It is more indicative of a large pericardial effusion rather than specifically tamponade, right?
I think so. Yeah. It's listed as one of the echo features, isn't it, of tamponade, the swinging heart. Yeah. Certainly you would be probably, if you've got a swinging heart, they're probably going to need that, need a draining.
Yeah.
But it's important to look for the other things as well.
Yeah. Good. So I guess that probably summarizes all the features of tamponade that we commonly use.
I think so. We've probably missed something really obvious.
Probably,
but hopefully our viewers can tell us what we've missed or what we've got wrong. That would be really good.
And I think it's just to recap. I think it's important that you use all the views available to you, that you describe very clearly and document very clearly what the findings are, and make sure that you've communicated all those things to people. Talking about its size and diastole, talking about where it's localized to, what the character of the fluid is. And that really helps in communication and helps when you're trying to phone a friend for a bit of help. Yeah, definitely.
And if you stick to that same thing every time, then you're less likely to miss something out.
Yeah,
you
for
make
sure.
a nice thorough assessment.
So next time, we'll be talking about when we would think about draining tamponade. Is it just a clinical diagnosis?
Controversial.
And then potentially some complications of draining it, and some key situations where it might not be just as simple as that. So thanks very much for listening, and see you next time.
Thank you. Bye. Oh goodness, Mark, this might take a while. I feel like I didn't have anything else to say after that, but maybe I should think of something to say.